the Director of Development for the Department of Medicine at Rutgers Robert Wood Johnson Medical School, and have the pleasure of working with Dr. Carson. Thank you all for being with us this evening, and I hope that you are all healthy and safe. During this time of social distancing, the Rutgers University Alumni Association is expanding its offering of virtual programs to highlight the important work being done at the university and to help keep alumni connected. Today, we are honored to have with us Dr. Jeffrey Carson. Dr. Carson is the provost, New Brunswick, at Rutgers Biomedical and Health Sciences, and served as chief of the Division of General Internal Medicine until 2015. He is currently the Distinguished Professor of Medicine and Richard C. Reynolds, MD, Chair in General Internal Medicine. Dr. Carson received his medical degree from Hahnemann Medical College, where he also was resident and chief resident in internal medicine. Dr. Carson is a board-certified internist who practices office and hospital-based internal medicine. He has been awarded 5 teaching awards and been on the annual Best Doctor list since 1998. He received 2 Research Mentor Awards from internal medicine residents. Dr. Carson's expertise in clinical trials has been recognized by his appointment to Clinical Trials Review Committee at the National Heart, Lung, and Blood Institutes, where he served as chair during his 5th year. He served as a member of the chair of multiple clinical trial data safety monitoring boards. All attendees have been placed on mute for duration of the presentation. If you have questions at any time, please feel free to send them via the Q&A option at the bottom of your screen. Following the presentation, I will read the questions to Dr. Carson as long as we have time, as for the time that we have left. It is now my privilege to turn it over to Dr. Carson.
Well, thank you very much, Melissa. And I'm assuming you can still hear me pretty well. Everything is still clear. Okay.
Yep, and we can see you.
All right. Hello, ladies and gentlemen, and thanks so much for joining me this evening on June 15th. So I have the privilege of speaking to you about our COVID studies, and what I plan to do over the next probably 35 minutes or so is first I'll introduce myself and tell you a little bit about what I do. You heard a little bit from Melissa, but I'll try to put it a little further in context. Then I'm going to describe for you our what we call the Corona Healthcare Worker Studies, and this includes the Rutgers Corona Cohort Study that we abbreviate RCC. We're in the middle of doing that project, as well as the Robert Wood Johnson University Hospital Healthcare Worker Study, which I'll show you the results from some of those findings from where we are with that particular project, and then tell you about some future studies that we are pursuing, and which I think you may find of interest. Then I'm going to sort of turn a little bit to some quick topics that you might find interest. The first is the Rutgers Saliva test, which has certainly got a lot of play in the news, and something you probably are interested in knowing about. We'll talk about what evidence we have when using masks and social distancing. There's an interesting study that just came out from the Lancet that you might want to know about. I'll briefly touch on vaccines, a little bit I can share with you. And then I want to show you some data on the risk of hospitalization and death, because I think it puts a lot of this in context, and then finally some concluding thoughts. So, when I give talks, this is usually the talk I give, okay? So I do clinical trials on blood transfusion, and this is the classic slide that I show. I give lots of these talks, and I'm presenting my research that which was looking at, in this particular case, a trial in hip fracture patients, looking at different transfusion thresholds, published in New England Journal of Medicine. We've been doing practice guidelines on red cell transfusion, published in JAMA. And I'm in the middle of doing a trial that we call MINT, myocardial ischemia and transfusion. I'm the principal investigator of this trial, where we're trying to enroll 3,500 patients with acute myocardial infarction and heart attacks. And we're studying different levels of blood transfusion to see if it impacts outcome. And when the COVID pandemic really hit New Jersey, we had enrolled 1,608 patients in this trial. We're trying to get to 3,500 patients. We're about ready to expand the trial, which is now in the U.S. and Canada, to Europe, where we had French and Spanish sites. And lo and behold, we were going to go to Brazil as well. And then COVID hits. And so I share this with you because, you know, I, like many researchers around the country, around the world, suddenly is faced with a pandemic, and our projects are put on hold. This trial was put on hold, although we just opened up recruitment again in the study, because, you know, the pandemic required both a situation where our research staff was safe, and going into the hospital where there were all the COVID patients might not be safe for them. And two is that, you know, we have this horrible problem here, and those of us who do clinical research and basic research are very interested in trying to contribute to how deal with this horrible illness and see if we can contribute and provide some research that maybe will help us get through this. So this is kind of where we were in March, and why I suddenly started doing COVID research. Now, what I'm going to tell you about is, you know, the first study I'm going to tell you about is the Rutgers Corona cohort study. And you can see here that my partners here are Marty Blazer and Ray Panari. Now, Marty, who, if you're interested in hearing him speak, apparently is speaking on Wednesday to the same audience, and I suggest you log in for his talk as well. Marty's an infectious disease doctor. He was recruited to run CABM, which is a research institute here at Rutgers, and he's absolutely amazing. That's all I can tell you. And Ray Panettiere is a pulmonary physician who does clinical research as well on asthma and COPD, and he is running our CTSA, the Clinical Translational Science group, with a huge grant from the NIH to build research at Rutgers. And so the three of us in the beginning of March suddenly get together, and we're faced with trying to see if we could build a project. And one of the absolute joys has been working with these guys because they're absolutely amazing, and we also have a great time together. Now, there are many, many others that have contributed to this, and this is really only a partial list, and I'm not going to go through their names. Dan Horton, Emily Barrett, and Marilla Gennaro, Jason Roy have been critical in the success of this project, but there are many, many others, and this truly has been a work from a huge number of Rutgers faculty and staff. So let's go to the meat of the project, and let's begin with what the aims of the RCC is, the Rutgers Corona cohort study. So our specific objective was to rapidly establish a prospective cohort to characterize the factors related to viral transmission and disease severity in a large healthcare system in both healthcare settings and in non-healthcare exposed community controls. So some of our specific goals were to assess the baseline prevalence of SARS-CoV-2 and COVID-19 in the study population. Now, let me digress for a moment and make sure we're all on the same page what these terms mean. SARS-CoV-2 is the name of the virus, and COVID-19 is the name of the clinical illness. So this is the virus, SARS-CoV-2, and COVID-19 is the illness. So this is the definitions that you need to be familiar with. So we're going to try to assess the prevalence, the baseline prevalence of these disorders in the study population, to characterize the natural history of SARS-CoV-2 infection in a diverse U.S. workforce, including the incidence of asymptomatic infections and critical illness, to determine the incidence of SARS-CoV-2 and COVID-19 in healthcare workers compared with non-healthcare workers, to identify the risk factors for acquiring SARS-CoV-2 and developing COVID-19, and finally, to determine the duration and extent of SARS-CoV-2 shedding. So these are all aims. I'm only going to show you a piece of this data because we're still in the middle of this project. So to begin with, we're recruiting participants from two hospitals, Robert Wood Johnson University Hospital in New Brunswick and University Hospital in Newark. So these are the two university hospitals associated with Rutgers University. And so we went to both institutions and spoke with the leaders of institutions, and they helped us and cooperated with us to recruit their staff and the faculty. And before I get into some of those specifics, let me just show you what happened to the number of COVID cases that are in our hospitals and the time that they began. So here in blue is Robert Wood Johnson University Hospital. Here in red is University Hospital. And then you can look at the dates. This is back in March now, the middle of March. And we started this project March 24th, where we enrolled our first patient, our first participant. Now, keeping in mind, for those of you who do research, we had to prepare a protocol. We had to get approved by our institutional review board. We had to get all our research materials together. We did this like in a week and a half. I mean, it was crazy. We were working every single night. We had calls every single night. And we enrolled over 800 people in less than 2 weeks between the 24th and April 7th or 8th. It was a monumental effort. And the reason we pushed so hard was because we knew we were in the beginnings of this pandemic, because it had been in New York, right? And it was coming south. And we knew that if we didn't get this study done and get it going very quickly, we wouldn't start recruiting until in the middle of it. So we wanted to get to the very beginning of it. And we were quite successful. And you can see that the rates of hospitalized patients went up to as high as like 275 or so at Robert Wood. And this went, that number of patients persisted for a good month or so. And at University Hospital, their spike was almost the same amount, somewhat lower. And then you can see what's been happening since then, that thank goodness, the numbers of patients in our hospitals has been falling rapidly. And now we're somewhere around 50 cases or so in both hospitals. One other point to make on this slide is that the second study that I mentioned to you is the Robert Wood Johnson University Hospital study. You can see we started this in late April, and at the time when the rates of infection were dropping. So now we have produced a manuscript that's under review, and I want to tell you about what we have found. So as I said, we enrolled 829 people, participants, and they're divided by about 2/3 were healthcare workers in our 2 hospitals, and 1/3 were non-healthcare workers, abbreviated non-HCW. Okay, and see the demographics of this group. 64% or so were women. Most were on the younger side, with only 10% being over the age of 60 overall. There's, like much of New Jersey, there's quite a heterogeneous community. I can't pronounce the word, sorry. You can see, however, over half of those who were enrolled were white, but a very significant number of Asians, Blacks, and other racial groups. You can see 12% were Hispanic ethnicity. Smoking was uncommon at 4.5% overall, although you can see the non-healthcare worker group was 6.4%. By the way, the non-healthcare worker group was recruited from non-healthcare workers from Rutgers University. So these are all staff and faculty from Rutgers who are in this group of non-healthcare workers. You can see in terms of chronic comorbidities, a comorbidity means that they have some kind of underlying medical disease like high blood pressure or diabetes, and about 1/3 of these participants had some form of underlying medical condition, and about 12% or so had symptoms of COVID in the last week before we enrolled them in our the first day of our project, right before our project. So the way this study works is they come in, they went to our clinical research unit, which we have 2 of them. We have multiple of them. They came to the one in New Brunswick at Robert Wood Johnson University Hospital. There's one also over in Newark on the Rutgers campus in Piscataway, and then there's the CRU up at University Hospital as well. So we had people coming there. We had an army of research coordinators that were collecting this data. And there's 2 main tests that we did besides finding out about their medical backgrounds and their histories and their age and such, is we did what's called an antigen PCR testing and an antibody testing. So the antigen testing is a test in which you're measuring whether the person has active infection at that moment. So there are a number of tests that are done to gather the sample. And the classic one, the one that's most established, is called nasopharyngeal swabs. This is a tiny swab that gets pushed through your nose into the back of your throat. It's a bit uncomfortable. And then you gather a specimen and then you put it into a tube. And with that, and then you can measure using a technique called PCR, the presence of viral virus. There are other techniques that are used to determine whether the person is antigen positive. So those include throat swabs, which is what we did. And the reason we did throat swabs is we could not get the swabs necessary to do nasopharyngeal. They were not available. You can also do nasal swabs. And then there's the saliva test, which I'll tell you about in a minute. All those samples are relatively consistent, generate data that's pretty consistent with one another. They're very close in terms of their yield in producing positive or negative results for the coronavirus. So that's the first test we did. The second test we did was antibodies. So this is a test. This is a blood specimen, and so our research coordinators, who were all in personal protective equipment, so-called abbreviated PPE, they were all gowned up. And they got the PCR test, and they also drew blood on all these folks. And then we developed, in one of our research labs at New Jersey Medical School, Murillo Gennaro, developed our own test for antibodies against the coronavirus. And so what did we find? Those are the key tests that we did. And we did these tests at baseline, at 2 weeks, at 4 weeks. We're doing it now at 8 weeks, and we're going to do it 3 more times, total of 6 times over a 6-month period. By the way, this study is now funded by the NIH. So what did we find? Well, we found as of June 1st, 8.6% of people who were PCR positive, so had active infection. And you can see that it was much higher in the healthcare workers, 11.9% versus 1.1% in the non-healthcare workers. Antibody positive was present in 8.4% of people. So that means, once again, that at some point in the past, they had coronavirus. They had COVID disease. And you can see that it was much more common in healthcare workers than it was in non-healthcare workers. And then you could see that the 89.6% had neither they were PCR negative and antibody negative. And then finally, sort of our bottom line in terms of what percentage of people in our study had evidence for COVID. And that's, we defined as either they had a positive PCR test or they had a positive antibody test. And you can see 10.6% of our participants were positive for either PCR or antibodies, and it was much higher, almost 3-fold higher in healthcare workers than non-healthcare workers. So what did our group look like? So let's look and see if we can establish what some of the risk factors were. So let me walk you through the table. Here in the first column is the healthcare role that our participants had. The first column here is anyone who's COVID positive, so they either had antibody or antigen positivity. And then we divided it up as well between our 2 hospitals. So here's Robert Wood and here's University Hospital. So the first thing that should strike you is, oh my, University Hospital had much higher rate. And we think that this partly relates to the fact that they are in Northern Jersey, where the pandemic hit much sooner. Beyond that, we're not quite sure why there was such a higher rate at this hospital compared to Robert Wood. In any case, who was positive? Who was positive? Well, you can see here the attending physician. So the attending physician is the doc who's in charge of the patient. It tends to be the older physician like myself, the real doctor, as some people like to refer us to. Their rate was really low, only 1.8%. Our residents and fellows, these are trainees. These are young physicians that we're training. Their rate was 3.1%, also quite low. But what's really striking here is, look here, our nurses our nurses, our frontline nurses who were taking care of these patients, their rate of infection was 11.1%. They were at the greatest risk. And you can see here it was even higher, 17.7% at University Hospital. And then other categories of healthcare workers. So this would include people who draw blood, respiratory therapists, physical therapists, and others. You can see that the rates were still quite significant, but not quite as high as they were in our nurses. Now, you might ask, well, where were people working? Well, we looked at the primary unit. Emergency room was clearly a place where there was a lot of disease. 8.2% were positive, were people who worked in the emergency room. Medical floor means that they're in the hospital, but they're not in a COVID unit. Almost 5% of them were positive. It turned out that people who worked in the operating room were also positive more frequent. And this had a lot to do with this cluster of it was in the Department of Orthopedics at University Hospital, where they had a cluster of colleagues, really it was nurses and doctors, who were positive up there. I think this is quite unique in this situation. Intensive care unit, you would have expected that we would have a lot more infections in people working in the intensive care units, because this is where all the COVID patients were. They were all on ventilators. They were very sick. Our ICUs were largely full of COVID patients only. And look how low the rate was. And I think the reason is because the PPE, the personal protective equipment really does work. And there was great care to be sure that people in the intensive care unit were protected. And you can see that we had designated COVID units. These existed at Robert Wood. At the peak, there was about there was like 5 or 6 different floors that were full of COVID patients. All our ICUs, as I said, were full of COVID patients. And you can see the rate was about 8%, even higher at University Hospital. And then in other units, the rates are somewhat lower. Now, let's look at what were some of the risk factors that might be associated with infection. And so one of the obvious ones would be, well, how much time did the healthcare workers spend in the room of patients with COVID? Okay. And you can see here, it makes sense. The more time they spent, the higher their risk of getting infection was. That makes perfect sense there. Okay. Now, what doesn't quite seem to line up as well is what about the percentage of patients in which they use PPE? And I think you can see here, this doesn't kind of line up. If someone uses PPE 100% of the time, you wouldn't expect them to have the highest rate. But the reason almost surely for this finding is that this is confounded. That is that those who are using PPE all the time were those who were exposed to the COVID patients all the time. So I think this is just explained probably by the same information that we see in the proportion of time that any one person spent in a patient's room. And then lastly, in terms of what I'm showing you, is the average number of patients with suspected COVID that they took care of. And you can see the more patients they took care of, the higher their risk of getting infection was. Now, we also correlated on these graphs three observations. The first is, what was the rate of infection in the 2 counties where our hospitals were located? So here in A is the rates of infection in Essex and Middlesex County, Essex being in red and Middlesex being in blue. The number of COVID-19 cases at each hospital, okay, once again, University Hospital is in red and blue is at Robert Wood in New Brunswick. And then finally, we correlated, and this correlation is less, is weaker than the other correlation, the proportion of positive test results from study subjects. And you can see University Hospital had a higher rate, as did the number of infections in Essex County at University Hospital. But you could see it was not as clearly linear as it was in those in terms of number of cases and number of patients in the hospital. And that Robert Wood, that really doesn't follow quite that same theme, does it? The rates were lower than we saw at University Hospital. And finally, in the non-healthcare workers, you can see that the rates are much, much lower. Okay, so that's a bit of a description of who these people are. So the next question you might ask is, well, what happened to them? How'd they do? Okay, so now this is going back to the baseline visits. So there were 829 people, 41 or almost 5% were positive. And you can see that initially 2/3 of them had no symptoms, asymptomatic, no symptoms, no fever, no cough, no shortness of breath, no loss of smell, no diarrhea, as some of the classic symptoms that are associated with COVID. And about 1/3 of them were symptomatic. But interesting, we followed them a little bit longer. A whole bunch of them who were initially asymptomatic became asymptomatic. And in the end, only 1/3 remained asymptomatic without symptoms. And what you can see here now is, well, what happened to those people? Well, of those who had follow-up, and this is later, you can see that 3/4 of them were not hospitalized. So they never developed severe disease, but oh my, 25% got sick enough to result in the need to be hospitalized. Okay, so that's a little bit about the natural history in our cohort. It's still very preliminary data, but it gives you a bit of sense about who they were and what happened to them. Now what I want to do is to show you some of our serologic data, which is looking at immunity. And so remember, this is the blood specimen where we look to see if the person had prior infection. And if it's positive, then it implies that they had prior infection. So I'm going to bring you over to the right-hand part of this slide, and you can see that during the first visit, only 1.2% of them had a positive test for immunity against COVID. But the healthcare workers were about twice as common as the non-healthcare workers. On the second visit, which was only 2 weeks later, 5.9% of the subjects of our participants were positive for prior COVID exposure. And once again, much more common now in the healthcare workers than in the non-healthcare workers. And then if you look at the concept of seroconversion, this says if your test is negative to start with and you repeat the study 2 weeks later, what percentage of them went from negative to positive, implying that they had an infection that led to the conversion. And this was 4.7% overall, with it being, once again, 3 times as high in the healthcare workers than the non-healthcare workers. Okay, so that's what I want to share with you in our preliminary data about the RCC. Interesting for sure. And you know, we have done more visits. We're going to be doing 3 more visits, and you know, we're putting together the analysis to see how our PCR positivity has changed, our antibody have changed. We're going to be correlating it with people's symptoms, with where they work, and lots of other questions that we should be able to answer with this large cohort. Okay, so the next study I want to tell you about, we call the RWJUH screening study. And the aims of this study was to try to screen all 5,000 employees at Robert Wood Johnson University Hospital, including healthcare workers and others, along with 1,200 medical staff. And the idea here was to find out what the positivity rate was for infection control, because we don't want our hospital workers to be transmitting the infection to our patients. Although I will tell you that was a major concern at the very beginning. It's just the opposite now. We think that the patients are transmitting the infection to our healthcare workers. Anyway, we started this, as I pointed out earlier, April 28th. And what we had was a baseline questionnaire, which pretty much aligned with the RCC questionnaire. We wanted to know where they worked, how much exposure they had, what symptoms they had, a little bit about their medical history. And here we did a throat swab. The hospital did the throat swab, and they also did the serology test. These were all done in-house at the Robert Wood Johnson University Hospital laboratory, where they had the ability to do these tests and do them quickly. We additionally collected some saliva specimen and serum, which we will use for future research. And then, of course, we consented them with the idea that we can look at the results. Okay, that's good research practice. In addition, that we could possibly invite them to be in future studies, including those of natural history, including treatment studies, as well as vaccine trials. So what have we found? Once again, so I'm just taking you right back to this graph that I showed you right in the beginning here. You can see when we started this study, we were on the rapid decline of infections. So you might expect that our rates of infection was low. And in fact, that's what we're finding. So, once again, our target population is 5,000. We have almost 3,000 who had consented. This is as of Friday. This is quite current data. 2,700 people had gone through the test. I actually volunteered. What the hell? I might as well get my test, which, by the way, were negative. And it turns out only 8 people were PCR positive, 0.3%. So we were at the tail end of the epidemic, the pandemic in our hospitals, and the rates of active infection were dropping rapidly. But look here, 8.5% of our participants, in fact, had evidence for prior infection with an antibody that was positive. So that's briefly what I'll tell you about the Robert Wood Johnson University Hospital Screening Study. I want to now tell you about some other research that we're up to and what's coming. So there's 2 clinical trials that we are ready to start very soon on. The first we call the TRIACT trial. This is a trial in which we're going to enroll 70 asymptomatic or mildly symptomatic outpatients who are PCR positive. It's a double-blind, placebo-controlled clinical trial. We're going to study a cocktail of 3 drugs, and you can see they're listed here. And the basic premise here is if you go to the history of what was effective at controlling HIV, effective was a multi-drug regimen. So even though one drug might not be effective on its own, like hydroxychloroquine, you saw that the approval for this was removed by the FDA just today. The combination may be quite effective because it works on different levels, different parts of the replication of the virus. And so we're going to be testing that in a double-blind trial. We're going to be looking at reduction of viral load. What that means is we're going to be repeating PCR testing, but we're not going to be just classifying it as positive and negative. We're going to count the amount of virus each time. And if the drugs work, you would expect the amount of virus to more rapidly fall in those who get the medicines than those who get placebo. And that will be our quick way of trying to establish whether medications might work. And if they're shown to work there, then we're going to ramp it up and do a big trial where we look at clinical signs and symptoms. The second trial to tell you about is a really cool one. And I don't know what Ray Panettieri's trial is going to be called, but this drug has got a catchy name of EDP-115. I'm sure you just rolls off your tongue. But in any case, this is a 60-patient trial, double-blind, placebo-controlled. And this agent is really unusual. It's a single strain of a small intestine targeted systemically immune modulating, monoclonally expanded, commensurate gut bacteria. How's that for a sentence? So it's a bug, it's a bacteria that's been modified, and it looks like it has the chance of treating effectively COVID. And this study is going to be testing this in more severe people who have lung problems, and we're going to be measuring whether it improves their oxygenation. This trial also should be starting quite soon. So what are the next steps for all our projects? Well, we're going to continue to follow up our people. We're going to have further serologic testing and integration with other data. We've collected a lot of blood specimens. We're going to do biomarkers. We're going to look for long-term follow-up with acute infections. We have the ability to do genetic testing. We're going to be looking at mechanistic studies coordinated with other cohorts and use the cohorts, as I said, as a resource to offer participation in vaccine trials, in treatment trials, and possibly in diagnostic studies. All right, so that's briefly what I wanted to tell you about our healthcare worker studies. Now I'm going to now digress a bit and cover a bunch of topics rather quickly, but I think ones that are probably interest to you and might be information that you can take with you that could be valuable. So the first to advertise, to promote the Rutgers saliva test. And I think if you're reading the newspapers, you can't help but have seen that those at RUCDR on the Piscataway campus, led by Andy Brooks and Jay Tishfield, developed this saliva test where people have to put a couple cc's of saliva in a little cup, and then it's perfectly safe. It's easy to collect, and it's very accurate. And it can be mailed in. It can be done at home. It could be done in the office, and then sent to RUCDR. When they started this, they were doing 10,000 tests a day, and they've been ramping up. It seems like if they buy certain equipment, they get another 10,000 tests, and I'm not sure what they're up to, whether it's 20 or 30,000 tests a day, but this is a big deal because testing, in my view, is one of the keys to try to keep this pandemic under control. So this is very exciting and something that I think was very important for public health purposes, for diagnostic purposes, and of course something, as all of us who associate with Rutgers is proud that we've developed this. So let's change the topic. Once again, I'm going to be jumping through topics. So the question here is, should you wear a mask and should you social distance? So I'm going to show you a study published like last week. Okay, is that recent enough? This was published in The Lancet, which is one of the premier medical journals just this month. And this was a systematic review and meta-analysis. What a systematic review means is that the authors went and looked at all the studies that have been done trying to answer the question is, does physical distancing, does face masks, does eye protection actually reduce your risk of getting SARS-CoV-2 or 1 or COVID-19, okay? So now this is all based on what we call observational studies. This means that they're looking at people that are using the mask versus those who are not. That's not the high quality evidence that you expect in medications where you require clinical trials to really prove, which is part of the problem that's been in the literature on hydroxychloroquine and other medicines, because it's clinical trials that give you the answer here. So it's observational data. It's probably the best we'll ever do with these kinds of maneuvers. So you can take that for what it's worth. But the evidence is really pretty strong, I think, that if you physical distance 1 meter, which is equal to about 3 feet, right? So 2 meters is about the 6 feet that people are telling you to do. You can drop your risk of transmitting infection by 82%. And so this clearly makes a difference. Trying to get people to actually do it may be a different story, but clearly this makes a difference. And for every additional 1 meter separation, you more than doubled the protection with data available up to 3 meters, where you can really reduce the risk substantially. Excuse me. Now, what about masks and respirators? They also have been shown to reduce the risk of infection by 85%, okay, with greater effectiveness in a healthcare setting where you're using N95 masks. But even in a community setting, you can see you can reduce the risk almost by half. So this is a very meaningful effect, and one that is something that we all should be using. So part of what I'm trying to emphasize to you is, do not back off from these measures to reduce your risk of getting sick. This is not the flu. This is a very bad illness. And lastly, the other way that this organism is transmitted is through the eye. And so eye protection has also been shown to reduce the risk of transmission. So I think this data, while certainly not perfect and not clinical trial, it's not based on clinical trials, it's about the best we're likely to have. And these are all very safe maneuvers, but require your careful attention to making sure this happens. And I can tell you, I'm not seeing it in a lot of communities that I'm walking around. People are backing off. They're not doing social distancing. They're not wearing masks. There's dialogue in some political circles that suggests it's not necessary. Here's the evidence, ladies and gentlemen, and I think that that's simply not true. All right, next question is, when can we go back towards normal life? Because this certainly is not normal life, like getting rid of social distancing. We all would like to do that. Well, it gets down to some basic concepts. And so the next concept I want to review that most of you probably know is the idea of flattening the curve, okay? So the whole idea here is, because this is a new virus that no one in our populations and any of our any humans around the world have had this infection. Therefore, there's a risk that it spreads rapidly, that you get a rapid rise in infection and you overwhelm the healthcare system. Okay, and so the basic idea here was to do social distancing, to stay home, to wear masks, but largely to stay home, and keep businesses closed. And it was devastating for our economy and for many businesses. But the idea here is, if you let everyone out and doing their normal activities, there'd be a huge rise in infection. We wouldn't be able to control it. The hospitals would be overwhelmed, and then the care would be significantly compromised. So the idea here is, by doing these interventions, that we can flatten the curve. Now, does that say the infection goes away? No, it does absolutely not go away. All it means is it's spread over a longer period of time, where we have enough healthcare capacity to take care of people who are sick, but it doesn't go away, which means that the idea that we can back off from these preventive measures, that's just not the case yet. That's just not the case yet. So it's not about the date, but rather the conditions tell us when we can back off, okay? And so what are those conditions? Well, it's when the number of cases and deaths start to decline, when we have enough tests available to be sure that the declines are correct, when there's enough masks and other protective equipment for healthcare workers to safely do their jobs, when hospitals can handle the surge of cases without being overwhelmed, and when the new cases have declined sufficiently so that contact tracing can be done to prevent resurgence. So these are all the concepts behind of when you can open things up. And I think our governor has done a really good job here. He's been very cautious. He's been very careful. He's been slow to open things up. Unlike other states where the rates are starting to take off again, he's been very careful. And I think he gets kudos for that from my perspective. So what are the other things? Well, when we have effective treatment, we have very limited treatments available at this point that have been established to work. And then, of course, when the vaccine is found, tested, and proven to be effective, and then implemented and administered to large numbers of people. So the next concept I want to go to is the so-called herd immunity, and this has everything to do with vaccines. So just to orient you, here in tan are people who are not vaccinated but not particularly sick. Here are people that are vaccinated here in blue. And then here in red are people who are not vaccinated, who are sick and contagious. So if all these people here were not vaccinated but healthy, so if this was all tan, then these people in red could be able to transmit this disease, which, by the way, for 5 days is often asymptomatic, and it's one of the great challenges in managing this condition, because that's when it's being transmitted. So if you have all these people who have never had the illness, therefore they can get the illness and it can rapidly spread. So what you want to do is develop so-called herd immunity, in which a large percentage, 70 to 80% of the population, have had the disease or have been immunized and therefore will not get the disease. And then those handful of people who are sick will not be able to spread the disease widely, and we will not have a pandemic, an epidemic of this disorder. So the basic idea, of course, is to vaccinate people. The idea that you can have everyone develop this infection naturally would be horrible, because there'd be so many people sick and so many people dying. So you need a vaccine to try to get to the point where you have herd immunity and the risk of infection becomes very low. And then we can go back to some kind of normality. So where are the vaccines? I think if you're reading the newspapers, there's a number of major companies that are developing them. There's some clinical trials that are going to begin shortly. A number of companies are starting trials this summer and early in the fall. And we are working with one of those companies. We're hoping that we will be able to use our cohorts to refer them to trials, vaccine trials. The big issue, of course, will be, however, will there be enough disease in our community? What a nice problem. If we have very little disease in our community, then we can't, this is not the right place to test whether the vaccine works. I hope in many ways that we do not have much disease and this is not the right place to test it, but I predict that it will be, because I'm seeing people, like, in my communities being much less careful. Okay, I'm going a little slower than I thought I would, so let me speed up a little bit. And I want to tell you a little bit about what's the risk to healthcare workers, okay? So this is data that comes from MMR. This is from the CDC, and this looks at healthcare workers who were admitted to the hospital, how many of them required an ICU stay, and how many of them died, and how did it vary by age, okay? And so, we're talking about healthcare workers today, and you can see the older healthcare workers have a much higher risk of being hospitalized. This is percentages. So 19%, 11% for younger, 9%. And for the youngest group of 16 to 44, it's 5.3%. You can see these are the numbers of people, of healthcare workers who had the illness, then got hospitalized, and then wound up in an intensive care unit, from about 1% all the way up to 7% of older people. So they get sicker and don't handle as well. And then if you look at what proportion of them die, it's very low in the young people. But you can see as the patients get older, it goes up to 0.5% die, and then 2% die, and those are age 65 and older. So, healthcare workers who get this illness who are taking care of you all, are taking care of our patients, are clearly at some risk of having very severe illnesses. And I think those numbers are important for you to know. Okay. So I'm going to skip this. And now the last part of my discussion, which will go pretty quickly, is I want to share issues of being a healthcare worker and taking care of COVID patients. And I refer you to this article that was in Sunday's New York Times by, I think, the author was Siskin, in which he interviewed a large number of healthcare workers from Columbia and from Massachusetts General Hospital in Boston. And in that piece, he has these healthcare workers describing how they're feeling and how dreadful it is to take care of these patients who you can't help, who you don't have good treatment, who are often, those who are most sick are dying alone because families are not able to come in, are not able to be by their loved ones, and are not able to help them, even though they're in the bed, they're getting oxygen, and they're dying. And this is so tragic for our patients. And what this article describes is how us as healthcare workers feel about this, and how emotionally challenging it is, and how difficult it has been for our healthcare workers. It's a piece that I urge you to read. So the last thing I want to go through really quickly is there's a program at Robert Wood Johnson Medical School. We call it the Heroes. And this is where someone nominates one of our nurses, one of our doctors, one of our residents, and says they have done something special to help take care of the COVID patients during this pandemic at our hospital. And I'm going to just show you a handful of pictures of people. I think probably 25, 30 people have been nominated in the last few weeks. I assure you that there are heroes throughout all our hospitals, certainly up at University Hospital. I don't have them, pictures of those folks, and to tell you more about that. But there's no doubt across the whole country what the way the healthcare workers have stepped up and have given everything they can to take care of our patients. These are some of the pictures of some of the folks here at Robert Wood. Susan Borokoff's the chief infectious disease. She's seeing every single case in the hospital with COVID. Rob Einstein is the head of the chair of emergency medicine. These are great docs, and Keith Lewis is the chair of anesthesia. Fred Wanisford really organized the COVID service in the hospital. He's the chair of the Department of Medicine, and like the kind of work that these folks did, I really strongly believe this sign is correct, that heroes work here at Rutgers Health, at our hospitals, but across the country. I mean, what our healthcare workers have done is just really remarkable, and under enormously difficult situations. So the last slide I want to show you is the guy who I view as one of the great heroes of our country. And this is Tony Fauci, who's the director of the National Institute of Allergy and Infectious Disease, NIH. So anybody who's been watching TV, reading the newspapers, has seen interviews with Dr. Fauci. And this is a guy who tells it like it is. And he's been in an incredibly challenging political situation, given the circumstances and the nature of the politics of our country. And he's managed to tell the truth, to share the key facts with the public. He's been key in organizing clinical trials on vaccines and medications. These trials are being funded by the NIH and are being organized by the NIH. So he, in the background, has been so impactful on what's happening with public health measures in our country, with new treatments, and probably with vaccine development as well. So for me, he's a hero. And besides telling you, wear the mask, do social distancing, don't let up. This infection is still lethal and incredibly dangerous and not controlled by any means. Do not let up on that stuff. And when you look for information to follow, there's a lot of discourse out there that's providing misinformation. Listen to this guy. He's a star. He's telling you like it is. And for me, he's a real hero. So I'm going to stop. I'm happy to answer questions, and thank you so much for listening in this afternoon.
Thank you so much, Dr. Carson, for that. It really was quite informative, and it is just great to see all of the amazing things that are happening at Rutgers. So thank you, and to you and your colleagues for all the work and the late nights that I'm sure have gone into this and will continue. So one question that we have is, would the elevated university hospital results be due to variances in socioeconomic populations?
Well, remember, these are healthcare workers, and so the socioeconomics are fairly consistent among the hospitals. I mean, Newark clearly has a lower socioeconomic group of people than probably New Brunswick, but healthcare workers are fairly uniform. My hypothesis is that the disease hit earlier, before we knew exactly how to protect one another, so PPE probably wasn't implemented as quickly. And I think the understanding of how to protect, ourselves as healthcare workers wasn't as well understood. That would be my hypothesis. Remember that the disease didn't get to New Brunswick until a couple weeks later in the high volumes, and that gave us a chance in New Brunswick to make sure we had more PPE, to make sure everyone was learning from all the horrible things happening in New York and Northern Jersey. And I think that could be the reason, but in the end, it's pure speculation.
Sure. And thank you, Dr. Carson. And you can feel free to put your camera on if you'd like, or I know you've been on camera, so if you'd like to take a break, that's certainly fine.
Camera off? Okay, I'm sorry.
No, it's okay.
No, that was off. I'll try to put it on if I can figure out how to do that. Go ahead.
Not a problem. So we received two other questions that are similar, so I'm going to combine them a bit. Aside from rubbing your eyes, would eye protection result in the same reduction in risk in the community? And do eyeglasses count as eye protection?
Great question. I don't know. I don't know the second question. I would think that, glasses are better than nothing, but, the eye protection that we use is either goggles. That's, you'll see some pictures of healthcare workers with goggles over their eyes, the classic goggles, or the face mask, which goes all the way down. That's probably superior, but are glasses better than nothing? Yeah, they might be. I don't know, but certainly you keep from your eyes.
Great, thank you. Here's another question that we have. Do asymptomatic people have lower viral load? Sorry. In other words, if you reduce the viral load through drugs, then are people more likely to remain asymptomatic? Is that something that you can tell from any of this data?
So we think that asymptomatic people, so it's typically the first 5 days is the classic time period that's described. If you measure viral loads at that time, it's often the highest then. So in the very beginning of the illness, the viral loads are the highest. So no, asymptomatic people who in the early part of their illness do not have low viral loads. Now later, say a week or so later, if they've been, if they've had that virus for that long a period of time, then their virus loads are probably lower. But I don't actually know the data for sure to tell you exactly what it looks like. But what I'm certain about is what I told you is that in the very beginning of the illness, the viral loads are very high, even though people are asymptomatic. And that's why, to add, that's why this disease is such a challenging problem, because that's when they're most infectious, right? That's when they're giving it to their family, to their friends, to others in their surroundings. And that's what makes it such a challenging disorder.
And here's another one, Dr. Carson. Of those who were symptomatic, were they more likely to also have a chronic health condition? And were you surprised, or how have you been surprised by any of these results so far?
Yes, I think they more often than do have underlying heart conditions. I mean, we know that when you look at those who do worse, those who wind up in the hospital, those who wind up on ventilators, those who die, often have lots of underlying medical problems that predispose to the more advanced versions of the disease. Am I surprised? Well, I don't know that. I mean, if you look at most medical disorders, those who have underlying diseases don't tolerate it as much. And you'll find that, from simple things like if someone's going to have an elective surgical procedure, the people that are less likely to do well are those who have lots of underlying medical conditions. So I think it's a truism with almost every medical illness that we have. And so, no, I don't think that's surprising.
Okay, thank you. And another question that we had, we have some folks with us from across the country. Somebody was wondering, are these saliva tests available in California?
They can, they're not, I don't think they're easily available. They can be absolutely, there's a system in place where they can be mailed in, but you have to get the kits themselves. I think there is an online way of doing that. In fact, I'm sure there is. If you Google it on the, you'll be able to find a link to a lab that will ship you a saliva specimen cup, and then you can UPS or FedEx it back to RUCDR right away, and then they'll do the analysis for you. So yes, it is available. I don't know how easy it is to get, but I am sure it's available. If you come to our office, for example, literally today, I was told by the person who runs our outpatient practice that the specimen cups are sitting in our office. So anyone who needs it, we can give it to you. But that's, of course, we're a little further away for you if you're in California.
Thank you, Dr. Carson. And that's great to know that they're readily available right in New Brunswick. To the person who did ask the question about California, we'll see if we can get you some more information for that afterwards. Just two more questions because it is about 6 o'clock and we just want to be mindful of your time, Dr. Carson. If somebody is immune to coronavirus, can they still act as a vessel like Typhoid Mary?
Typhoid Mary, well, I don't know. So let's talk about the immunity question. So the immunity question goes like this. In someone who's had infection, who has a positive antibody test, are they at risk of getting a second infection? And if so, if they have a second infection, are they as likely to transmit the infection to others? So the question that you asked was the latter one. And so I think the answer is we don't know yet. What I would say to you is that 95% or so of virus infections like coronavirus, if you've had it once, you're immune. and not at risk of having it a second time. Now, whether that will prove to be the case with this illness, that is yet to be established. One. Two is that the tests that are measuring immunity are mostly brand new. There's a lot of tests that are being challenged about the quality of them, how good they are, whether they are accurate or not. And so I think we're at this point, we're in what I call an evidence-free zone, which means we're not sure yet. We will figure this out soon. And I think the odds still are, if you've had the illness, then you're not likely to get it again. But we don't know that for sure. And but my expectation is we'll be able to figure that out over the next 3 to 12 months.
Thank you. Okay, so last two questions, and then for those, if anybody else on the event with us this evening does have some questions for Dr. Carson, I'll go ahead and give you my email address as we wrap up at the end, and feel free to send me questions and we can get some answers for you. So the second to last question is, if a drug lowers viral load, will that help minimize the severity of the illness?
Well, that's our hypothesis. So the TRIACT trial that I briefly mentioned to you is our idea here is to take people who are positive PCR, so they have the disease, that they're either asymptomatic or mildly symptomatic, and get them on drug and reduce the viral load, and with the idea that that would prevent the progression to symptomatic disease or more advanced disease, and allow them to recover more quickly. That's what we want to test. There's every reason to believe that that could be true. I mean, almost every infection that we know, if you treat it early, when people are not that sick, then they're more likely to do better. So there's no reason to think that that's not going to be the case, but we haven't proven that. That's what the trials have to establish.
Thank you, Dr. Carson. And last question to wrap up for the evening. The work that you and your colleagues are doing, and all of the work that's been done across Rutgers, I mean, you went through a few studies, and it's ongoing and certainly important work. If someone on the call, or if they're interested in helping you or being able to help move these along, so what are some ways they can do that?
So we have a volunteer, a little, I'll call it, one of our administrative staff works with volunteers. In fact, earlier today, I gave a little talk to our volunteers who are now helping us with the hospital study. If we wind up expanding the hospital study across the RWJ Barnabas system, which we're exploring doing, if that happens, we're going to need a lot of help. So, feel free, of course, to volunteer. And, the best way to do that is you can email me, or you can email Melissa, and then we'll get you to Judy Argon, who's the person who's been coordinating our volunteers. And, then of course, any financial support would also be welcomed. And that's something that you can talk to Melissa about, because she helps with that as well. So, we'd be grateful for any help that you might be able to provide.
And Dr. Carson, thank you so much. Again, thank you for all of your work in this area and for your time this evening. We certainly appreciate it. And just so everyone has my email address, I'll go ahead and follow up with folks as well afterwards, but my email is Melissa, MELISSA .Magyar, MAGYAR @RUF, as in Rutgers University Foundation, .rutgers.edu. And again, we'll go ahead and I can send that out to folks so you have that, but please feel free if you have any questions or are interested in volunteering, we'll go ahead and get all that information over to Dr. Carson. So thank you all for joining us. And again, Dr. Carson, thank you so much for your time this evening.
You're welcome. Stay well, everyone. Please don't let your guard down. Please don't let your guard down. This is going to go on for a while, and it's a really bad illness. So please be careful. Take care, everyone. Thanks again. Bye.